you, Dr. Hoy. Dr. Thompson, you're recognized for 5 minutes for an opening statement.
Good afternoon, and thank you, Chairman Pitts and distinguished members of the committee for holding this hearing. I'm here today to provide ASHP's perspective as a professional society that represents over 42,000 pharmacists who practice in hospitals, health systems, and ambulatory clinics, and has been a recognized leader for over 20 years in the development of guidelines on sterile compounding, non-sterile compounding, and guidelines on working with outsourcers. The event caused by the New England Compounding Center resulted in 61 unnecessary deaths and more than 700 meningitis cases. ASHP strongly believes that the authority and accountability between the FDA and state boards of pharmacy needs to be clarified. We believe that compounding outsourcers that prepare customized sterile preparations that are not commercially available should be held to the highest standards for quality, including relevant current good manufacturing practices, and should be required to be registered with and routinely inspected by the FDA. Further, we believe that these entities should not copy commercially available products except in the cases of drug shortages or to make a medically necessary variation that meets patient-specific needs. The drug approval process in the United States is the gold standard and should be maintained as such. However, it is important to recognize that there are many legitimate and medically necessary compounded sterile preparations that simply are not available from a brand or generic manufacturer in the strength or dosage forms that patients need. U.S. hospitals prepare a vast array of compounded sterile preparations from FDA-approved products every day in order to meet patient-specific needs. The compounded medications that hospitalized patients need range from simple intravenous admixtures to complex customized medications that are not available off the shelf, such as multi-ingredient cardioplegic solutions for heart surgery, epidural pain medications for women in labor and delivery, concentrated pain medications for cancer patients, and adult medications prepared in concentrations that can be safely administered to babies and children. Where necessary, hospitals enlist the services of qualified compounding outsourcers for some preparations for several reasons. For example, some hospitals may not have the necessary equipment or facilities to prepare some high-risk sterile preparations, which is sometimes the case in small and rural hospitals. Or they may face medication shortages for commercial products that can only be replicated by outside suppliers that provide customized compounded sterile preparations. They may also enlist the help of outsourcers to prepare FDA-approved sterile products and ready-to-administer packages in the strength and dosage forms they need. The evolution of the compounding outsourcing industry over the past decade has outpaced the ability of state and federal laws to keep up, creating legal and regulatory gray areas between state and federal government. Unfortunately, it just isn't as simple as calling these large-scale anticipatory compounding entities a pharmacy, a repackager, or a pharmaceutical manufacturer. They are something in between each of these, but no one category fits them perfectly. Recent bipartisan Senate legislation addresses the need for clarity in distinguishing between compounding by a pharmacy and the activities of a compounding outsourcer. It assigns responsibility and accountability to the FDA for regulating compounding manufacturers while preserving the accountability for pharmacy compounding to state boards of pharmacy. It also establishes a user fee program to help ensure that the FDA has the resources it needs to effectively regulate compounding manufacturers. Because of the potential nationwide scale of these operations, we are concerned that state boards of pharmacy may not be able to provide adequate oversight of these facilities. Many state boards may not have the resources or expertise to evaluate whether a pharmacy has crossed the line and become a manufacturer. With respect to the regulatory framework proposed in the draft legislation by Representative Griffith, ASHP is concerned that the regulatory environment that allowed the New England Compounding Center to operate as a pharmacy would remain intact. In other words, if authority between state boards of pharmacy and FDA is unclear due to lack of accountability, we would be concerned that neither FDA nor state boards could be held accountable if an entity were licensed as a pharmacy but was also preparing sterile compounded preparations without a prescription and selling across state lines. In addition, our understanding of the draft legislation is that FDA would only be permitted to inspect a pharmacy that may be operating as a large-scale compounding entity if FDA has received a submission from a state board of pharmacy. This ability for FDA to have the necessary access to records and inspect a compounding entity would be contingent upon state boards being properly equipped with trained personnel to determine if an activity appears to approach manufacturing. We are concerned that FDA may not be fully accountable if the state board does not notify the agency. Further, this approach would imply that state boards would inspect all prescription records and sales transactions of each licensed pharmacy in their state to identify those entities that may be acting outside the scope of traditional pharmacy compounding. And therefore, would defer to the FDA. We do not see that as realistic for many state boards and therefore believe that these types of compounding outsourcers would be more appropriately regulated by FDA. In conclusion, ASHP remains completely committed to working with Congress, the FDA, and other stakeholders in developing a reformed regulatory framework for pharmacy compounding Thank you, Chairman Pitts, for holding this hearing on this very important public health topic.
Chair, thanks, gentlemen. Mr. Francis.
Dr. Thompson, in your testimony you note that none of the classifications of repackager, pharmacy, or manufacturer fits neatly with the regulatory needs of the large-scale compounder or outsourcer. Do you believe that asking FDA to regulate these operations as manufacturers, but leaving these specifics on how they're regulated up to the enforcement discretion of the FDA is a good policy?
Sir, reflecting on the Senate bill and how the FDA, how they've defined a compounding manufacturer, they defined it as an entity that is not preparing a product in response to a prescription and is engaged in interstate commerce as a proxy for risk. We think as this industry has evolved over the last decade to provide necessary service to hospitals and clinics and others, that it's really created this gray area that there isn't federal legislation or regulation for. So we do think it's necessary to help clarify what those entities do, which provide very helpful services to healthcare organizations and patients.
Have you looked at the enforcement discretion that's in Congressman Griffin's bill?
Well, we don't think enforcement discretion is a good policy, and that's the thing now, that there are these companies out there that are selling products for anticipatory use that under the law really isn't allowed, but they do fill a need. They're doing it under good standards in many cases, but those need to be clarified. We think in the Griffith draft that in some ways it creates a third category without calling it that. It still allows entities to prepare large-scale products without federal oversight. It leaves it to state boards of pharmacy, really the same environment that exists now that caused NECC. It leaves it to the state boards to call the FDA and identify something. State boards are under-resourced, they don't have the expertise, and they're not manufacturing-level inspectors.